Let's begin the day. As we witness the union of technology and healthcare reshaping medical practice, it's time to delve into the transformative potential of smart hospitals. In this new era, understanding how these high-tech health centers will redefine our treatment process is more crucial than ever. In our upcoming panel discussion on the topic, The Future of Healthcare, How Smart Hospitals Will Change the Way We're Treated, our panelists will explore what the future holds for healthcare. Without any further delay, I would like to invite the session's moderator, Professor Dr. Stephen T. Wong, PhD, PA, Department Chair, Distinguished Chair, Professor, and Center Director at Houston Methodist Hospital, and panelists, as well as the other panelists, Ravi Ramaswamy, CEO of RV Consultants, Marcia Domecq, Psychotherapist at Self-Care SOS by Marcia, Dr. Shinya Yamamoto, Founder and CEO of Lincoln Innovation, Inc., and Nagendra Rao? Excellent. Nagendra Rao, President of Sales at Trigent Software. Take it away.
Good morning. I hope you have a good night's sleep after a long night. Welcome to the first section for the day on the Smart Hospital. My name is Stephen Wong. Before I start, I'd like to each panelist probably introduce them a little bit more. Go ahead.
Hello, my name is Marcia Domecq. I work as a psychotherapist in a hospital clinic setting. I've been working as a mental health professional for the last 30 years. And I also work as an entrepreneur after hours and at night. I'm actually here not necessarily to talk about tech. These guys are the tech experts. My contribution has to do with the balance of technology and all of the things that we've been talking about so far in this conference. If you were not here for day one, either virtually or in person, please go back to day one and revisit that. I was very, very impressed with the speakers and what they had to say about mental health being part of this bigger picture. Especially in today's world. COVID hit us pretty hard. And I was able to watch firsthand, working with the docs and nurses, the impact on it. And I also was able to see kind of the unwritten rule that we don't talk about feelings in hospitals. And if you take the time just to talk to a nurse, it won't take long before they're in tears. And it's almost as if this pandemic happened and there was no grieving process, and the next conversation was productivity. And so I'm here to talk about this from a few different perspectives. One would be as a mental health clinician, and then also as a patient and as a co-worker. So in 2019, I became sick very quickly overnight. I started with neurological problems, went to my local clinicians and got sent to Mayo Clinic. So I was at Mayo Clinic over a span of about a year and a half and found out that I had small fiber peripheral neuropathy. I had a rare neuromuscular disorder called myotonia congenita. It's actually the same gene as the fainting goat disease. So we get tight when we wake in the mornings, but we don't fall down like the goats do. And then it's fine. You're just tight in the beginning. And found out that I had a fast progressing rheumatoid arthritis and also psoriasis. And so I talked with the doctors about what is it that went wrong. I was perfectly healthy one day and got very, very sick overnight. And all that they could really offer me is a diagnosis and meds. And I said, I don't understand. I have so much happening within my body. If I take meds, I see their side effects. And how in the world are you going to diagnose me? And so they actually were fine with me not doing meds. And I was in 5 different departments within Mayo Clinic. And the other piece of what was happening was that I had internal tremors that were 24/7. And so I would wake up in the middle of the night. 3 o'clock seemed to be the time that I'd wake always. And I was shaking, thinking that something was horribly, horribly wrong with me. And I went to the doctors and I saw a movement specialist. And he hooked me up to the machines that are able to tell if there's external tremors happening. And it didn't measure them because mine were internal. And thank goodness they didn't say it's just anxiety, because I diagnosed anxiety and I know that my mind was calm, but my body was in movement. And so they did all their testing. They gave all the diagnosis, recommendations for meds. I didn't take any of them. And they said, thank you, you're done. And I said, I'm still shaking. How can I be done? And they said, I'm sorry, that's all we have. So I took the time to dive deep into everything. I was doing occupational therapy, physical therapy, chiropractic, anything alternative that you could basically think of, and was able to reverse all of the symptoms. And I kept looking for that answer. How was it that I'm perfectly healthy one day and very, very sick the next day, and found out it was mold and stress? Yes, thank you.
Thank you, Marcia. I'm Nagendra, and I am president of Trigent Software. We are a 3,000 people IT technology solutions company out of Boston and India. We work with companies like United Healthcare and clinics, and 40% of our business comes from healthcare. You see, technology is not exactly how it turns out to be. There are many complex and small problems that we solve, and we work in this area and help companies solve problems and also improve patient engagement, deal with data in a proper way, and automate processes and systems to optimize costs and make their processes more efficient. Thank you.
Good morning, all. My name is Ravi Ramaswamy. I've been the CEO of RV Consultants. Prior to that, I've spent about 10 years with Philips. Before that, 10 years, another 20 years with Larsen & Toubro, an Indian company. Been in the industry for 40 years, out of which 30 years I've spent in healthcare, evangelizing affordable healthcare for emerging markets. My job has taken me to across 70 odd countries to understand the way the dispensation of clinical care actually happens on ground, so that we can come up with effective, cost-effective, and clinically relevant solutions to those markets. And post my retirement, I now work with a lot of the global healthcare organizations, more as an advisory capacity in terms of trying to see how we can impact mankind in a positive way. Thank you.
So I'm Shinya Yamamoto from Tokyo, Japan. So thank you very much for the time today. And I do actually founder and the CEO of my own company, Lincoln Innovation Inc. But also I do work as a visiting professor at the National University Hospital, and also to business school for global MBA program. Then I have been closely working with Japanese government as well for the decentralized clinical trial, and also real world evidence for the biopharmaceutical industry. So I would like to discuss about the how we can, realize a smart hospital in globally with those panelists today. Thanks so much.
Thank you, everyone. Yeah, I'm very happy to have everyone share their expertise from different perspectives. Briefly, my background is, as mentioned, I'm a scientist at Houston Methodist Hospital, a professor at Cornell University. Previously, I was professor at Harvard at UCSF, but I have about 40 years experience in healthcare. I run the product development and chief architect for Philips for many years. And also, actually, I was a VP for Charles Schwab, developed the Sword.com before going back to do research in medicine, which I have passion for many years since then. So, without overdue, I like define the term. Smart hospital is a very abused term. When you ask 10 people, you probably get 10 different answers. So, being academic, would like to put some perspective, a boundary. A smart hospital, the term really started around 2000s, if you first hear the term. Originally, it's a hospital administrator tried to using advanced technologies together for information systems to improve the efficiency, reduce costs, improve outcome, patient care, all kind of things. This is how the smart hospital, the term come in. And over time, we evolve, right? You see the EMR, electronic medical record, PACS, picture archive communication system, all this being implemented system. And people start checking outcomes, quality control. And nowadays, we even have robotics in the surgical room. This is a concept of smart hospitals started 2000. But in the last about 10 years or so, the landscape changed a little bit. The concept actually expand further. People realize that there's no one hospital system can be completely integrated. No one can do everything under one roof. And our concept of patient care in America, particularly, I think shifted from disease management to health management. That's the reason in this conference you see a lot of people talk about wellness, talking about rehabilitation, things like that. Because this is really a evolving things. Because as a consumer, as a patient, we're getting smarter. We get a lot of information. We know what we're looking for. At the same time, for insurance company, they realize pay for procedure cannot scale. Sooner or later, we need to cut it down. And this reason they have an incentive, look at the total health management instead of individual disease episode. And so we are talking about an exciting topic which is evolving bigger than what is originally formed. It's forming an ecosystem. It covers not just a hospital. In a way, smart hospital is a hospital without walls. Reach out to many sites of your whole life cycle. You can think from that perspective, the panel will discuss about it. It's pretty broad. In that sense, we touch on many areas, whole life cycle. So I'd like to get started with a couple of questions for the panelists. You're welcome to chip in and answer questions. And Ravi, you have a lot of experience, my previous colleague at Philips. And you have a lot of experience global and GE and Philips, and you see a lot of things. You are the front end implement stuff, technology in the hospital systems in India and Asia and Europe. How you see, now we talk about AI, I see a lot of AI theme. How you see AI, this type of technology will merge into this evolving smart hospital concept?
I think AI has a significant role to play, but then before we get to AI, we need to understand certain facts about AI. AI is basically a sort of a rules engine, intelligent rules engine, which basically helps you predict, given a set of parameters, what the best outcome and what could be the best, the way that the disease is going to navigate itself and what the treatment line has to be. But before we get to that point, the AI is contingent, the quality of the data that goes in. Now, when we really want to create intelligence of sort, we really need to understand the data actually has to reflect the trend that the patient has gone through, saying, yes, the patient walks in on day one. These were the symptoms that was reported. The medications prescribed, the interventions prescribed were A, B, and C. We do the next check. We know what the outcomes are. And it continues over a period of time. And then when you start putting all this data together, you can form a cohort and then draw intelligence out of it, saying, for this population, this type of symptoms, these were the interventions that were done, and this is what the outcomes have been. And that forms the basis of an AI. Now, the question that comes up is, we have a lot of data with us, but none of them are annotated in a manner which is consistent to what is actually needed for a quality engine of sort. And I think that's where we are stuck. So saying that, yes, I've got millions of scans or data makes no sense to me unless you have a timelined intervention plan tied up to it so that you know what has gone in, what the output has been over a period of time so that you can derive meaningful information out of it. I think that's where we are all struggling in terms of the quality and the quantity of data that you really need for pulling an engine together like this.
Yes, it's a very interesting point. You talk about quality of data. Shinya, I'd like to ask you a question since you work on the clinical trials and clinical research area. That's the area the smart hospital is very focused. How to put the trial faster, efficient, less costly, things like that. How you see the direction?
Okay, thank you very much. From the perspective of clinical study or trial, after COVID-19 pandemic, we are currently on the really remarkable turning point in the industry. So we are currently discussing about the decentralized clinical trial by using multiple technology like artificial intelligence or blockchain, data platform, wearable device, IoT sensor, etc. How we can realize a cost-effective and much quicker clinical study for the patient, and then also the valuable study drug or clinical medical device to be launched. So this means more patient-centric, or we can say hospital-centric by using a technology. So for example, the mobile nursing, which nurse or doctor is visiting to the each house of the the patient. Then also we need to use patient data as well for the feasibility study or recruiting as well. So this is a big discussion in the government or regulatory agency, and also the leadership of biopharmaceutical industry as well. But also the key person or discussion is always coming from academic, key opinion leader like professor or physicians, medical doctors. So the most important point is not only technology, but also the operation of the hospital side. So all stakeholders related to the clinical operation is super important to be understand, and how to implement the cutting edge technology to the current operation. So this is super important to understand such discussion about the smart hospital is not only about the technology, but also really important realistic or current operation. And then we need to discuss from the technology side and also medical side as well. This is my opinion. Thank you.
It's an interesting point. Just for people understand, hospital getting very complex. Not just providing patient care directly, especially with this smart hospital, with EMR, PACS, digitization of data. People start looking at a way to accelerate the clinical trial, drug trial, device trial, using the digital archive the big hospital system have to identify patients for trials. And in a way, it's a lucrative business if you think about it. And some patients have disagreement. It's a very controversial area. And a while ago, some institution in New York digitized all the microscopy image and into a big archive, and then sell it to farmers, make tons of money, tens of millions of money, and it's completely legal. Our law does not catch up with it. But the patient revolt, because when they send in the consent form, the patient only agree for research purpose, not using the data for making money. So this is a kind of pros and cons. Think about it. In a way that it definitely improve our care, improve our revenue, improve our efficiency, or even improve our bottom line. But at the same time, we also running a very tight ropes. We will touch on the area that the patient right, patient privacy, all kind of things that we never think of before. With that setting, I'd like to ask Nagendra about these pros and cons you see at the smart hospital, since you do a lot of implementation for the hospital side on these type of things.
Thank you. We see smart hospitals as places where they say pre-PPM, preventive, predictive, personalized medicine. To do this, you need democratization of data. Now, there are two issues in democratization of data. Either people are not ready to share data, We have many companies who have come to us saying, I bought these clinics, now I cannot drag that data into my systems, and we help them. One is technology-driven impediments. The second is trust. People are not ready to trust enough to share data electronically with the other entities, be it pharmacies or clinics, or even patients are not ready to sometimes share data. So that is a big impediment towards building smart hospitals effectively. Secondly, the smaller hospitals don't have enough money to invest to get this kind of data investments done. So that's another impediment we see. Secondly, smart hospital is often compared to an airplane where the pilot is giving the care, but there is a whole airport behind it supporting it. Is all the systems, processes, people trained to operate the smart hospital just like an airport does now. Now, that requires a humongous amount of effort. Thirdly, we see care moving towards like hospitals at home. Now there, we have so many areas. I was in a remote area recently. Internet connections are bad, people are not trained, and people don't know how to operate devices, the wearables that they would use to give hospitals at home. So that requires a huge amount of investment. So how will that happen? That's another area. The fourth and the last one is cybersecurity. If we move to smart hospitals and you have wearables and you have AI making decisions and machine language building new models to provide care, what will happen to cybersecurity? There are many bad elements around. Somebody talked about a digital Ebola virus, which suddenly paralyzes the whole system. We knew what happened to Southwest a year ago. Now, when we move into the era of smart hospitals, will such a virus come in and paralyze the whole system and jeopardize people's lives? So these are some impediments we need to consider, and we need to move very carefully, do pilots, and move towards a launch in that way. This is my opinion.
It's quite interesting point about, I mentioned earlier on, smart hospital is really a ecosystem. And that's what Nagendra is saying. Not just everything hospital-centric. It's also about deliver the care to the other side, which are outside the hospital wall. Ultimate goal is really achieving the total health of the patients, not just manage a disease as episode as currently we are charging this. The trend is going that way. A very important area is really often neglected actually in at least in the American system is really a mental health, which become a hidden cost and burden emotionally, financially to the country, which a lot of them is outside hospital wall. And how do we using this smart hospital to improve this large population of relatively less neglected populations? It'll be interesting. Marcia, it'll be interesting upon.
Yeah, so I work in a hospital and I had to look up the term smart hospital. I don't know how many of you have actually heard of smart hospital. I hadn't heard of the term. And so it makes a lot of sense. Like from a patient perspective, my sister had open heart surgery. She was in the regular patient room. And if you think of our patient rooms, they haven't really changed all that much. And we have such technology at our hands, and we have AI, we have smart things. You know, one of the things we really did learn from COVID is that the isolation impacted the patient and impacted families and impacted the world at large. And so concepts like being able to have the ability to have a smart tablet right there, and all of a sudden, you know, your family, your friends, or whoever, you can talk to them, you connect with them. My sister, when she had open heart surgery, she actually had fallen and was on the floor for 20 minutes and had no way of being able to get to the call for the nurse. Have an aunt that was 102 years old, and in her later days, she needed to press that button and she wasn't strong enough. So like thinking of it from a parent or patient experience and how we can really use that technology is going to be really important. Me, myself, my patient experiences, they found a rare brain tumor. It wasn't a cancerous brain tumor. But I needed to have a gamma knife surgery. It was amazing. It actually was an outpatient proceeding. Lasted about an hour and a half. I went out to breakfast that morning. I went to a show that night, and they had stopped my brain tumor without even cutting my head open. But I had an equally different experience with the neurological parts. I saw 6 different specialists. Nobody could stop the internal tremors. And so I had to really take my health into my own hands. And so being able to have a framework that encapsulates all of this, all of the things that we've gone through in terms of the mental health struggles that we've had, and how do we put AI together with the mental health, with the fatigue that all of the clinicians are feeling. And so I did develop a framework for that. I do have a few pointers for you if you want to take a few notes. I think the main thing is just to ask the question, and this can be done in 2 seconds. How are you, and what do you need? We actually had a supervisor come around at the end of the day and ask all of us clinicians, how are you, and what do you need? So we can do that with our coworkers. We can do that even with our supervisor and administration. We can do that with our patients. We also really need to think about the skills that we need to be honing right now. I mean, we have a little bit of a post-COVID world right now. We know political stuff is coming. We know all these demands. We know financial stuff is coming. Use that time to really build those skills. Deep breathing actually can be as effective as some of the short-term medications for anxiety. So really build your skill set. If you think of observing as if you were in a lighthouse and you're looking at your patient and you're trying to figure out, where is that patient? Are they in the deep water? If they're in the deep water, you're going to need to get mental health in there and involved. I work in an adult partial hospitalization with patients that have either tried to commit suicide and they've been in the hospital and that they're on their way out, or else it's a prevention for going into the hospital. And we can get as tech savvy as we want, but you know what? If that patient commits suicide, it doesn't matter. So we have to have mental health at the forefront. So it's worth the time. I started as an integrated behavioral health worker in the setting of the docs and nurses. And so basically how we were able to integrate that is the docs and nurses would ask the question, how are you doing? If you see tears, bring somebody in. Like really talk with your hospitals to see if they can have a mental health person. So I would go in, they would be on to their next patient. You only have 10, 15 minutes, right, with your patients. And so I would have a conversation with them about mental health. A lot of them had never stepped inside mental health. And they were, yes, I really want that. So there's some ingenious ways of being able to like combine all of it. It isn't the answer just to say, oh, you need mental health, I'm going to send you somewhere. Like we need to really be implementing that within the same system.
So a very interesting point about the outpatients, the Gamelan. As I say, the most you can see a lot of services actually moving outside the hospital, not just a standalone. You can see more facility being moved outside the whole ecosystem going forward. But having said that, actually, you guys, we are in the healthcare business for a long time. We realize that the recent trend going on is country dependent, of course. In US, the trends toward really a corporatization of hospital, the hospital getting bigger and bigger. And the one who survive are the marquee system of a huge chain. They have the resources to implement this technology to train their staff to be more competitive. So what happened to all these mom and pop small hospitals? Well, they're not that small, but compared to this giant, they are small. When they don't have investment, how can they survive? I'm not quite sure this is a trend, good or bad. I mean, but recently there's, because of this new concept of smart hospital, people start thinking about maybe it may not be everything corporatization. Maybe it's a retailization hospital system. You have a whole ecosystem. Hopefully people partner each other instead of horizontal, instead of vertically integrated. And I don't know if this is happening or not. We still yet to see. But I'd like to hear from Ravi, because you have a lot of experience in Asia, in Europe. I don't know what happened in that area.
I think even in India or even other parts of the developed world, we do see consolidation of hospitals happening. There are sort of greenfield and brownfield hospitals that are either acquired or they sort of start off fresh more so on the specialty side. That is what we get to see now. So from that perspective, I think there is a ton of investment that is going both from the private side and from the government side in terms of building up infrastructure for the hospital. But having said that, given the norms that we are in the developing world and also in the rural parts of the developed world, the amount of investment that is needed to sort of get the care to the level that we want across the segments of society is almost impossible. And that's where intelligence and AI actually comes into play. Like, for example, you talked about the cost, and I will touch that in a minute. Take, for example, an ECG machine. An ECG machine today is the cardiologist. What if I were to sort of make it so cheap that it goes into the hands of a general physician in a village? Now, the question that comes up is saying in a rural segment, the general physician may not be qualified enough to read the ECG. Fine. So what I would possibly do is take the ECG, push it up to the cloud or any other server system where I have an algorithm which basically interprets the ECG and gives the result as a first level of diagnosis. Now, when you start doing that, that's the way that you are going to decentralize care, and that ECG could be actually given free of cost. We have done economics to say that even if the machine is given free, if you start charging on a per transaction basis, you will still be able to recover much more than what you would have if you had sold the ECG as a CapEx model. So there is a certain amount of transformation, the commercial transformation that is going on hand by hand, side by side, along with the business and the technology that is driving it. So we can sort of come to a point wherein we will be able to sort of drive the level of care that we want with the resources that we have using the technologies of date. What I told you on ECG is basically a hub and spoke model, so to say, which can be sort of decentralized. The same is the case with remote ICUs. Remote ICU is basically, in India, for a population of 1.3 billion, we have got 500 intensivists out there. Indonesia, population of 280 million, we have got only 50 intensivists out there. So these intensivists are the ones who are basically able to drive outcomes into a critical care setting. Now, what if I had a capability by which the data from the remote side comes on to a hub where the intensivist sitting in a tier 3 or a tier 4 hospital is able to look at those data and then draw interpretations and advice on to the doctors, a GP or an anesthetist at the far end, in terms of how to manage the care. So basically what we are now trying to do is to use the capability that exists in the center out in the spoke, and that's certainly possible using technology. And once you start looking at per transaction cost and paper use mode and stuff like that, you are able to drive the cost down, and the volumes will also kick in, which will sort of push the cost to the left. So there are ways and means by which this deployment can be done, and we do get to see this happening in the emerging world for sure.
It's a very interesting point. Actually, I didn't think of it. As I mentioned, about 30 years ago, we have 10,000 hospitals in America. Today, we're about 4,400, something around that number. Our population increased in the last 30 years, definitely more than 30%. So what's that mean? The hospital getting bigger. And it seems like smart hospital is really smart. Maybe we can make it that instead of centralized, we make it more democratic, decentralized. If the technology cheap enough, small guys can also implement those technology effectively and work with the big guy to create a total ecosystem. No one knows everything. A complete vertical integrated system has a pros and cons. And I think healthcare is not a pure business. Healthcare is about humans and about ethics, about human health. And money is the only measurement, like the other corporation industry. We need to take care of the mental health issue, depressions, patient feelings. All these are important why we're in healthcare for. And maybe with this smart, cost-effective technology, like IoT device, ECT, if you implement effectively, the small hospital clinics can play with the big guy, work together, provide a total integrated care.
And also bring in the commercial transformation into it, the business innovation into it, along with the technology innovation, so that the combination of it can make it really effective and drive the cost down, as also pushing up the outcome. So you start meeting all the elements of the quadruple aim, which is basically enhanced patient experience, enhanced caregiver experience, positive outcomes, and lowered cost.
It's very effective. Actually, interesting. Actually, I think about it. The IoT device recently make a lot of change in clinical trials. It's starting changing how clinical trial being conducted. I don't, Shia-san, you have any comment on that?
Yes, this is definitely the IoT device sensor, including the multiple wearable device, is now changing our environment in the biopharmaceutical industry or clinical operation. So as everyone mentioned that smart hospital means we can say a really data-driven platform based on the hospital, because the data is coming from patient. That means coming from hospital. So the such IoT or sensor is now really focused on the patient data, how we can collect the variety of type of data from the patient, not only like daily medication, but also our daily activity or maybe some phenomenon from our body. So now lots of startup companies or investors or industry side are trying to develop such the product to work with technology vendors.
Yeah. Lorena, you have any comment on this since you work on the software support side? Have you seen?
Yes. Yes, IoT devices are getting advanced. I'm reminded of some work we did for Walmart, where they wanted to have personally controlled healthcare records for all their employees. And it was an Intel incubated project. And when you get onto a treadmill, there is a device which sends your data on a daily basis and you can upload it to your EHR. There was also a device which goes onto the weighing scale, and every day you can upload it to the EHR. So IoT devices will play a very major role in smart hospitals, and it will, the only thing is there'll be so many of them, and there'll be trillions and trillions of signals and big data coming in. And again, the problem of analyzing this data comes in. So IoT devices and data would be the key for smart hospitals and also moving healthcare to home. That's my thought.
Yeah, it's a very good point. Actually, you mentioned recently a couple of, I'm sitting on some board of the device company. In the clinical trial, in fact, IoT is very popular, but the experience is making minimum, only one endpoint, one IoT. Don't load the patient with tons of it. If you're at home environment, patient won't, not like ICU, you load the ICU patient with tons of information. In home environment, most of them just, they experience so far. In the beginning, they loaded the patient with all kind of IoT devices, finds completely useless, not get anything done. So they only measure one thing, your heartbeat, just measure your heartbeat. And measure your sleep, by the way, sleep is very hard to measure at home. I suddenly realized that. I don't know how your sleeping pattern. We sleep a lot, we don't know at night. The device don't really measure our sleeping pattern very well. So you try Apple, it's not reliable. At least all the clinical trial people told us. And it's very challenging. That's the reason when you have a sleep problem, go to a sleep center. At least make sure they have a device, make sure you correct diagnosis. There's one measurement on this part. For in terms of the mental health, I still want to get back to the area. I think because our system, at least US system, we clear ICD-9 code, ICD-10 code, we charge by certain thing. And cancer, all these things, and heart disease, those are charged by procedure. And it's done by hospital. Mental health, yeah, I talk to you, I give you a drug, nothing much you can do about it. I just wonder your experience so far, how the technology and this new big data may help in this area. There's a large population of people out there.
Yeah, I think the main thing is just really keeping that patient experience at the forefront, whether it's just a conversation with the patient or whether it's technology. When the doctor was meeting with my sister, he basically was having a conversation about there's several different valves that we need to try. One of them probably will work, but when your heart stops beating, and he kept going on, and he says, "Are you okay?" And she's like, "No, I'm not okay. You just talked about my heart stopped beating." And he says, "I'm so sorry. I have this discussion with patients all day long." So just really keeping at the forefront what's happening with the patient, what's their experience of what's happening, whether it's AI or whether it's just a conversation with the patient, and just really keeping hope. That's the main thing that you can give that patient at that point in time is hope. And our job really is about self-care for ourselves, for our coworkers, and for administration.
So yeah, I think one thing you realize that our mental state affect our physiological state a lot. We are stressed. We are more susceptible to a lot of diseases, cancer, all these things. Your body just release things to trigger certain things. A healthy, balanced state, it help make the patient healthier and then recover faster. The wellness, rehabilitation, all these things. In the past, during the pay-by-procedure era, people don't care too much. Now insurance companies say, I cannot pay forever like this. We already hitting 20% of GDP, $4.3 trillion last year alone. And a country cannot keep going this way. And really find a smart way to make it more cost-effective and effective. And I think the smart hospital is one of the recent movement which move away from the original 2000, which is big corporation, big hospital, incorporate EMR, robotics, all kind of thing, only heavy capitalization approach to make the hospital very competitive. I think is now going forward is we look at the patient as a total health smart hospital, not just a disease management, but health management, and look at the hospital without wall. And this is more promising. And promising is not altruistic, really driven by payer. Payer say, I can't afford to pay so much forever. You put a Da Vinci machine again, I charge you double my price in surgery. I can't afford every time you do that. The outcome is not necessarily good. And also the way we measure outcomes in hospital, we don't measure well. We do midpoint outcomes, we do surrogate outcome. We rarely have total outcome of patient, which is the patient's cure. And very hard to get those data. If we don't have an integrated network, in hospital alone, we don't have it. And that's the way that the smart hospital is going to become an ecosystem, incorporate many things. So overall, I mean, this is an exciting movement. Next time people talk about smart hospital, its smartness doesn't mean that it's costly, like 2000. It can be like cheap IoT, you using smart way or integrating together. You can deliver adding values, adding the quality to your service much better. You can partner with other people, not just your own hospital, your small clinic, maybe the nursing home, the other thing. Effectively talk. Now the communication is so cheap, IoT is so cheap, internet is so cheap. It's a way to how to integrate the workflow together besides the one single entity. That's what the smartness. Ultimately, we want the patient at better outcomes. This is the ultimate goal we are here for. And I think all these high-tech, high-tech without high touch is still missing. I think this is the part that people, I think this generation of smart hospital, we are smarter to know that we're able to add some high touch back into the business to make it effective. So I think I like, yeah, go ahead.
Yeah, in fact, I just wanted to give a scenario to you here, Stephen, saying that we know that for a rate, 15 minutes is spent on looking at the, in talking with the patient, and the balance 45 minutes looking at the image and talking to working with the RIS and stuff like that. This was we actually saw. I walk into a clinic, the doctor keeps a mobile phone besides us, and he keeps talking to you for 20 minutes, okay, which is double the time that he would normally spend with you. The entire record, the phone picks up all of what you are talking about, and by the time he tells you, okay, fine, the diagnosis is already done, I have whatever has to be done, you will find it outside. So you walk to the outside to the room, and a technician hands over the entire prescription to you with all the details in it. So by doing this, what you're actually doing is to double the time of the doctor on the patient, make him a lot more attentive and looking into what your actual needs are than spending the time on the EMR. By doing so, you are able to triple his throughput in terms of what he's actually doing. Like say, in an hour, he now looks at 3 patients, wholly attending to what the patient needs are, but at the same time, not compromising on the quality of the outcomes or the diagnosis that needs to be done. So that's where it is heading. It's not only restricted to the hospital, you also see this percolating down to the diagnostic centers and the physician's office and stuff like that.
Yeah, Ravi, that's a very good point. I like to echo that. Actually, nowadays, physicians or nurses are really tight. Right? You understand the matrix measurement, and for radiology, time is money. Spent with the eyeball. That's how get income from, and the technology can help. In fact, if you look at it, for those of us working in hospital, we realized a lot of nurses and physicians actually doing a lot of mundane screening, standard procedure scoring. And those things can be actually replaced by machines. The final decision can be done by human, but you don't need to tie up a triage list to look at something if AI can do much better. So we have for example, we have a stroke. ER room come to stroke. You know, we miss 50% of stroke in this country. We miss 20% and over-diagnose another 30%, about 50%. Very poor rate. Stroke is very difficult. There are many reasons. And we actually do an AI system to look at video and audio voice, standard protocol, automate. And we compare with the humans, actually better than human. This is not surprising, by the way. AI, when you focus, when you have enough good annotated data, that's very important. Data quality is important, as Ravi say. When you have good annotated data, AI can beat human on a specific disease. This is a very proven many times. Humans are very good at, we have looked at the whole heuristic. We look at the whole spectrum of things. AI so far cannot generalize enough to understand what it is. But at least for the stroke phase, we do a lot of automation of triage. We do automation of imaging. We also do automation of the NIH scoring, which is standard procedure to monitor the patients. The end of the result is the neurologist is very happy. He said that they spend about 30 minutes to an hour per day just doing this mundane scoring procedure. When right now we help them to spend more time with the bedside, which AI cannot automate. This is the part the machine cannot do, human touch. We need to spend more time, give more time, use the technology, automate the part which is mundane, repetitive, give more time to the caregiver, closer to the patient bedside. That's what patients need them most. I think this is how the healthcare is. I think this totally agree with this part. I think this is smart hospital is also smart in the high touch, as I mentioned this area before. I think this is a very good talk. We have a couple minutes. I don't know if anyone any burning questions, and happy to ask the panelists full of a lot of experiences in this area. Anyone? Don't be shy. Yeah, you can use the mic. Or you can
So thank you very much for the question. So from my perspective, based on my current activity, we are trying to implement the GPT-4 or federated learning technology to collect such qualified data from hospitals like a system. So that's one of our challenge.
Or maybe I can go for it. In the sense that the handling of data is always a challenge. The question is, if you look, data could be in form of numbers, it could be in the form of images, it could be in the form of cine loops, it could be genetic data. The question that comes up is, how are we going to integrate all this data and come up with a meaningful insights in terms of looking at a object or looking at an organ from a 360-degree perspective? The answer is no. We have platforms that do all of it today. The answer is no. And with the amount of data that is actually coming up, you really don't know what is valuable and what is garbage. So the industry per se is actually struggling in terms of how to sort of pull all of this together to create a data lake of sort by which you can draw meaningful information as and when needed. So the answer is, we have not solved the problem yet. We are still working on it.
Thank you. You can ask the panelists after the talk. Be interesting. Thank you.
Thank you very much.
Thank you.
Thank you.